I request Secretary Dr. Pandey sir for his talk on some difficult esotropia entity. 7 minutes, sir.
Thank you, Dr. Shubhangi. We'll be talking about some difficult esotropia entities as So one thing we should keep in mind when we talk of strabismus that we are actually born with two parallel monoocular visual systems, and binocularity is a learned language. It's like learning language. So whatever happens, if there is a problem, if there is an obstacle, so this binocularity is not going to develop, and we will have a strabismus. Same thing happens with infantile issues, for example, that because of the problems with binocular wiring, you get into all these difficulties. And these are, we are trying to fix them at the peripheral level, whereas the problem is at the central nervous system. So we got frontal light, we got into binocularity, and all these problems arose. And this union is a bit fragile. If it is broken, then it can end up in divorce. So we must ensure that when children are younger, they need to have proper correction of glasses and proper alignment so that they don't get into all these issues. Now, if there is a poor wiring in the occipital cortex, then you will have return to primitive monoocular systems. As I said, there will be primary inferior-oblique overaction and superior-oblique overaction because monoocular animals, they use their obliques rather than recti. If the fish has to go down, the obliques are at work. Once we got binocular, obliques were put down and recti took over. So that's one thing. Another thing to keep in mind. DVD is because of the dorsal light reflex. As the animal is turning, as it goes up, the eye which is having less light tends to go up. So you have DVD. Same way about latent nystagmus and SPA. So all these things which we see clinically, they have a bearing on our past embryologically. So esotropias, infantile esotropias are we understand they are very different. The difficult entities as I would like to talk about is infantile, partially accommodative, esotropia with myopia, particularly with high myopia, esotropia with cerebral palsy, CVI and hydrocephalus, and ROP and esotropia. Now, infantile ones, we know they have large deviations, they are freely alternating, by and large, they don't have amblyopia, and there's pursuit asymmetry and DVD and inferior-oblique overaction, all these factors give them away. So we know that this is infantile. At times, they may have an accommodative component. Important to take care of that accommodative component. Otherwise, you will end up doing surgery, which is not appropriate, or they may also have a DHD. If you don't take that into account, then you may do more surgery and they go for consecutive exo. These are the associations. Very often you have a cerebral palsy, you have low birth weight, you have prematurity. So all these things are associated. So whenever you have a child, you must look at these things also. And there are a lot of functional deficits in infantility, like absence of motor fusion, absent for stereopsis, alternating monoocular suppression, subnormal VPs, asymmetric monoocular tracking, and asymmetric motion perception. So it is not just misalignment. A lot of things are happening in the brain which need to be looked into. This is showing if they are not treated early, they will have inferior-oblique overaction and DVD, and all those issues will appear. Of course, it can happen in earlier age group also, even if they are treated, but the chances grow higher as if they are treated later. So treatment is mostly surgical, and early surgery is important. You must do them before 8 months or by 2 years, and if you do them after 2 years, you are likely to have poor binocularity. So it is always important to catch them young and do surgery early. Accommodative, we just refractive, no problem. Partially accommodative and non-refractive with high ACY ratio, they are difficult to handle at times. So we need to look at that. Is it partially accommodative? If they have not looked after in early age, they will go for partially accommodative. Or if there is anisotropia or there is astigmatism, so all those factors, or the amblyopia. This is showing a young child, the parents get very disturbed. Suddenly they find the eye is gone into ESO. And so it's very alarming situation. This is partially accommodative. Despite correction, they don't get corrected. So you need to correct their entire error. At times you have done under cyclogic. So the entire hypermetropia has not been uncovered. So you need to do them under atropine. And some of those who are with high ACY ratio, they may even be myopic or emetropic. So it is not essential that they are all hypermetropic. This is showing another partially accommodative deviation. Quite often they have amblyopia in one eye and they may have an isotropia also. So need to look at that. Non-refractive accommodative usually have high ACY
Can I
ratio. They may need
request-
bifocals.
Sir, can I request you to, yeah, there are 2 minutes left.
Yeah,
But,
I'll finish in 2 minutes. So these need Farden maybe and bifocal glasses. So as I said, Farden or bilateral MR recession in these cases. And this is acute acquired competent esotropia. Dr. Rishikesh has already talked about it, and we had a lot of these in COVID, so I'm not going to talk in detail about this. This is another one because of we had this acute acquired competent esotropia in a young child, and he had CNS tuberculomas. You can see extensive tuberculomas in this child, in the brain, particularly in the cerebellum, and these ones can give rise to acute acquired competent esotropia. So if they're not responding, so you need to neuroimage. By 3 months, if they're not responding, neuroimaging is important and should be done. This is the same child after treatment, he improved, and this is another condition which we encounter once in a while, esotropia with high myopia. What is happening here? Because of the axial growth of the eye, the lateral rectus gets displaced down and the superior rectus gets displaced medially. So this pushes the globe down and in, and just conventional surgery like recession and resection is not going to work. So some kind of myopexy has to be done in these cases, and if there are large deviations, the MR gets very tight. So that also has to be recessed by and large if they are over 40 prism diopters. Like in this case, you can see both eyes are in a convergent position. Then you have esotropias with high myopia with ROP. The ROP myopia is different with prematurity, that there is the problem with the cornea and the lens. They are not emetropizing. So it's not about the axial length, it is more about the cornea and the lens, which are not losing their power because of lack of emetropization. So the problem is with the anterior segment rather with the axial growth.
Can you please conclude, sir?
I finished.
Yes.
This is esotropias with cerebral palsy. These, as I said earlier, they are very special children because they have a lot of other cerebral visual impairment and all those issues. So they need special care. This is with CFUM. And to conclude that we have to have these conditions which need a special treatment, and we need to catch them young and treat them accordingly. Amblyopia has to be treated. If they are infantile, don't treat them like other ones, because they are separate class of conditions where CNS, the brain is involved, and eye, it is just being manifested. So we have to look at the brain and the effects rather treating the peripheral aspect of it. Thank you.